Hey everyone, and welcome to This Explainer. I am so glad we're tackling this together today. We are laser focused on getting you a truly comprehensive overview of this material so you can walk into your NSG 331 Week 11 quiz feeling completely prepped and totally confident. We're going to dive deep into chapters 6 and 7, which really get into the weeds on the economics, the legal issues, and the care continuum for older adults. Basically, think of this session as building your essential gerontological nursing toolkit. By the time we wrap up this explainer, we are going to have these concepts absolutely locked down, so let's just dive right in.
All right, here's our roadmap for today. We're breaking everything down into 4 crucial, easy-to-digest topics. Number 1, navigating care settings. 2, financing healthcare. 3, legal rights and capacity. And 4, identifying elder abuse. This is the exact structure you need to compartmentalize the information and totally ace that upcoming quiz. Let's not waste any time and jump right into our first topic.
Okay, Section 1, Navigating Care Settings.
So as a gerontological nurse, knowing exactly where a patient goes and understanding the environment they're in is honestly just as important as knowing how to medically treat them. Moving a patient from one healthcare setting to another is actually considered one of the single most stressful events an older adult can go through. In the field, we often call this the revolving door. And here's a pretty staggering statistic for you. Did you know that 1 in 5 older patients is readmitted to the hospital within just 30 days of discharge? 1 in 5. That is exactly why nursing involvement is so absolutely crucial here. Nurses actively serve in roles like transition coaches, care coordinators, and care managers. And why? To reduce those preventable readmissions, improve patient outcomes, and, of course, lower costs.
Now, when a patient transitions into a skilled nursing facility, you really need to know the 2 distinct levels of care they might receive. Let's contrast them clearly so you don't get tripped up. Subacute care is intensive. It has a massive emphasis on rehabilitation, it's largely reimbursed by Medicare, and it typically lasts anywhere from 1 to 3 months. The absolute key takeaway here is the expectation that the patient will eventually be discharged. Chronic care, on the flip side, is long-term. This is for the frailest of older adults who truly require 24-hour ongoing support. They might not need intense acute medical interventions, but they are highly dependent on help for their basic activities of daily living.
Let's talk about a major paradigm shift in these long-term care settings. It's called the culture change movement. This was heavily backed by the Omnibus Reconciliation Act of 1987. You'll often just hear it called OBRA. Basically, because of OBRA, nursing homes have been transforming from this rigid, sterile medical model into a much more nurturing home model. And this shift is all about empowering the residents. It ensures the environment doesn't just feel like a cold hospital ward. Instead, it respects their individuality, it fosters real relationships, and it allows residents to actually make the daily decisions they're used to making in their own lives. Okay, let's wake up that testing brain of yours. Time for a real-time knowledge check drawn straight from your practice material. Here we go. A nurse is beginning discharge planning for an older adult after a total hip replacement, requiring continued nursing care and physical therapy. Which environment best suits these needs? Is it an assisted living facility? Maybe home care? And the correct answer is a subacute care unit. Think back to our comparison a minute ago. The combination of intensive nursing care and physical therapy, paired with that clear expectation of an eventual discharge home, perfectly hits the nail on the head for defining the subacute level of a skilled nursing facility. Let's drop a second quiz question to really test your understanding of the Resident Bill of Rights. A nurse explaining the Resident Bill of Rights realizes further teaching is needed when the resident states which of the following. For this one, I want you to think about what a resident has the absolute right to control versus what is just dictated by the day-to-day operations of the facility. Right, so if the resident says it will be nice to choose which nurses care for me each day, well, they're going to need some further teaching. Here is the crucial point. While residents absolutely have the legal right to manage their own finances, keep their health info private, and be fully informed about any medication changes, dictating daily staff assignments, that isn't covered under the Resident Bill of Rights. Moving right along to Section 2, financing healthcare.
Now, you might be wondering why we're talking about money. Well, understanding how care is funded isn't just a job for the hospital administrators. It's actually a vital nursing skill, especially when you're assisting in discharge planning and making sure there's continuity of care. Long-term care is incredibly expensive, and those costs are quite literally only going up. Funding this care relies on a really complex web of sources. It's paid for through Medicaid, Medicare, private insurance, and heavily out-of-pocket. As a nurse, you have an obligation to help your older patients navigate these financial hurdles using your expert advocacy skills. To advocate effectively, you've got to know the Medicare alphabet soup. Let's break this down simply for your quiz. Medicare Part A covers medically necessary hospital services and select skilled services. Part C refers to Medicare Advantage plans. Think of Part C as being similar to an HMO or a PPO, which actually replaces Parts A and B. And Part D? Just think D for drugs. It's an optional prescription coverage plan that was created back in 2003, and the premiums for it actually vary based on a person's income and their covered medications. Let's challenge you with another crucial practice question to really cement this in your memory. Which part of Medicare helps cover some skilled nursing facility care, hospice care, and home health care under certain conditions? The answer is Part A. If it involves skilled nursing facilities, hospice, or acute hospital stays, you are almost always looking at Part A. Also, do not forget this vital testing point. To even be eligible for Medicare in the first place, a patient must be eligible for Social Security. That's a big one. All right, Section 3, legal rights and capacity. As nurses, we are on the front lines, right? We spend the most time with the patients, which means we are often the very first people to notice those subtle changes in a patient's mental state that might indicate a change in their capacity. But what exactly do we mean by capacity? Clinically speaking, capacity is defined as the ability to understand a problem, its risks and benefits, alternative options, and the consequences of a decision. But, and listen closely because here is the critical legal distinction you must memorize. Only the courts can declare a person legally incapacitated. Not nurses, not doctors, only the courts. When a patient's capacity is in question, we immediately look to power of attorney documents. Let's place these two side by side because they get confused all the time. A general POA usually only has the right to make financial decisions and pay bills. That's it. However, a durable POA is explicitly required to make health-related decisions for a person when they're unable to do so themselves. Now, if there's no POA in place and a person is deemed legally incapacitated, the court has to step in. You need to contrast these two court-appointed roles clearly for your quiz. A guardian is a person appointed to be responsible for the individual themselves, providing care, having custody. A conservator, on the other hand, is strictly appointed to control the finances of the person. So just remember, guardian equals person, conservator equals money. And that brings us to our final section, Section 4, identifying elder abuse. I want to shift to a much more serious, urgent tone here because identifying and acting upon elder abuse isn't just about passing a nursing quiz. It is quite literally a life-saving clinical skill. We often tend to think of abuse purely in physical terms, but it is so much broader than that. Abuse includes medical abuse, which means subjecting a person to unwanted medical treatments or the improper use of chemical restraints. It also includes undue influence. This is a sneaky form of exploitation where an abuser might use false affection to isolate a victim from their friends and family just to gain control over them. That being said, you absolutely must be hypervigilant for physical red flags during your nursing assessment. Please do not simply brush these findings off as normal aging changes. You need to memorize this list. Look for bilateral bruises, multiple bruises of various ages, unexplained burns, hair loss that suggests pulling, and a history of repeated ER visits or frequent falls. Also, take careful note if a caregiver is the only one doing the talking during a visit or if they demonstrate overly frustrated behavior. So what exactly is your game plan if you suspect abuse? Walk through these active clinical steps with me. Step 1, you have to assess the presence of immediate physical danger. Step 2, if danger exists, seek immediate help right then and there. Step 3, if they are not in immediate physical danger, your job is to keep communication channels open to gather more information and assess the situation further. And how do you open those communication channels without shutting the patient down? By using non-judgmental, open-ended statements. You'd say something like, I noticed there's several bruises on your arms. Tell me about what happened. The absolute golden rule in nursing education is assess first, conclude later. And remember, as a student nurse, if you ever suspect abuse in the clinical setting, your immediate responsibility is to notify your instructor or the primary nurse so they can step in, do a thorough assessment, and follow all the proper reporting guidelines. Wow, we have covered a tremendous amount of ground today. But before you go, I want to leave you with this overarching provocative thought to chew on before your quiz. What issues are involved in adapting to transitions and role changes in later life? I mean, really think about it.
Think about the profound loss of a home, the stress of navigating incredibly complex medical bills, and facing scary changes in your own independence. Understanding the gravity of these transitions is what will make you not just a student who passes a test, but a truly exceptional, empathetic gerontological nurse. You are primed, you have a comprehensive overview of the material, and you are going to do incredibly well on your Week 11 quiz. Thanks so much for studying with me on this explainer, and good luck out there.